Hi, everyone, and welcome to another edition of OrthoCarolina's monthly webinar series. My name is Taylor Bellamy. I'm an OrthoCarolina spine surgeon based in Winston-Salem, and I'll be talking about cervical stenosis and myelopathy today. This is being live streamed on our Facebook, LinkedIn, and YouTube platforms. And please don't hesitate to ask any questions in the comments section, and I'll try to address them all at the end. Next slide, please. So a little about me. I'm originally from Atlanta, Georgia. I went to the University of Georgia for undergrad, then moved on to Emory University for medical school, as well as my orthopedic surgery residency. Then I finally made my way outside of Georgia and moved up to Boston for my spine surgery fellowship. That was at Harvard University, where I trained at both Massachusetts General Hospital and Brigham and Women's Hospital. Next slide. Before we jump into what cervical stenosis and myelopathy are, let's review some general anatomy. So as you all may know, your spine is made up of 24 bones called vertebrae that are all stacked one on top of another, with the disc in between each one that acts as a shock absorber. This specific issue happens in the cervical spine, or the neck, which is comprised of the 7 vertebrae at the very top, which connects the base of your skull down to your torso. Your spinal cord, which is the yellow structure in the picture to the right, travels from your brain all the way down your lower back through the middle of these vertebrae within the spinal canal, and it gives off nerve roots at each level that supply your arms and your legs with the signals needed to detect sensation and move your muscles. Next slide. So what is cervical stenosis? Stenosis is just the medical term for narrowing or tightening of a space. So when we say cervical stenosis, we're saying that the spinal canal, where all of our nerves and the spinal cord live, is starting to narrow. This can be caused by many different things, but 2 of the most common are disc herniations, which you can see in the picture to the top right, and then also simple degenerative changes, which you can see in the picture on the bottom. As we get older, we develop wear and tear on our spine, and eventually you begin to see these degenerative changes throughout the spine that we like to call spondylosis. Think of spondylosis as the medical term for arthritis in the spine. As this happens, the discs can bulge, we can develop bone spurs, and our ligaments can get larger, which can all start to creep into the spinal canal and cause that stenosis or narrowing of the spinal canal. Next slide. As these things happen and you develop cervical stenosis, it can begin to make the space available for the spinal cord to become more and more narrow to the point that the spinal cord itself can actually become compressed. And when the spinal cord is compressed, it can begin to have difficulty functioning how it's supposed to. We refer to this as cervical myelopathy, which just means dysfunction of the spinal cord. So again, cervical stenosis is the narrowing of the spinal canal, and cervical myelopathy is dysfunction of the spinal cord due to compression. So now we're going to talk about what this spinal cord dysfunction looks like. The signs and symptoms of cervical myelopathy can be very subtle and vague, which can often lead to the potential diagnosis of cervical myelopathy being overlooked. But it's actually a very prevalent problem, with up to 5% of people over the age of 40 having it. Patients are often misdiagnosed or get a delayed diagnosis, which is part of the reason why I like to talk to you all about what cervical myelopathy is and how to detect the early signs of it. Those signs and symptoms include numbness and tingling in your arms and hands. This can sometimes feel like a pins and needles sensation. You can notice weakness, especially in your shoulders, arms, and hands. Patients can begin to have issues with their balance. They may start stumbling or falling more than usual. You may notice that going up and down stairs is more challenging than it used to be because you feel like you may fall. Often patients describe having a death grip on the handrail when doing stairs because they're so scared of falling. And finally, patients can start to notice issues with their coordination in both their hands and their feet. It may feel like your hands are clumsy and you may have difficulty doing things like buttoning a shirt or writing with a pen or pencil when you were previously able to do these things without issues. Next slide. Now, a lot of the signs and symptoms we talked about on the previous slide can be caused by other things besides myelopathy, which is part of what makes this such a challenging diagnosis sometimes. It's our role as physicians to help you work through these symptoms and to reach a diagnosis. So if you notice any of these symptoms, it's best to contact your primary care doctor or reach out to us at OrthoCarolina so we can initiate a workup and help you figure out what's going on. At your visit, we'll perform a physical exam that includes testing the strength in various muscle groups, checking your sensation and ability to feel. We check your reflexes, and we have you perform tests which evaluate your balance and your dexterity. Imaging is also an important part of the workup. Often we start with an X-ray, which allows us to look at the bones and your overall alignment. And if further evaluation is needed, sometimes we have you get an MRI or a CT scan. All of these imaging studies help us diagnose you and determine the best treatment for you. Next slide. So once we have reached a diagnosis of cervical myelopathy, it's a good idea to meet with a spine surgeon, such as myself, so that we can discuss our treatment options. Cervical myelopathy is generally an operative issue that we recommend surgery for, and I'll explain why in a minute. However, in very, very mild cases, or in patients that are too sick for surgery, we occasionally offer non-surgical treatment. This can involve physical therapy to help maintain your function, or medications aimed toward decreasing inflammation and pain. Now, it's very important to recognize that non-surgical treatment will not create more space in the canal for the spinal cord. In other words, it does not treat the underlying condition. And that's part of why we generally recommend surgery for this. Our goal with surgery is to create more room in the canal and take the pressure off the spinal cord. When you have cervical myelopathy, patients will see a gradual decline in their function. This means that without surgery, this isn't something that's going to go away. If you look at this graph to the right, we would expect all those symptoms that we discussed earlier to become more and more severe, which will affect patients' ability to function and live their life. So if left untreated, patients with cervical myelopathy will gradually fall further and further down this green line. And in severe cases, they can even lose their ability to walk effectively or use their hands to take care of themselves. Our goal with surgery is to halt the progression and prevent things from getting worse. Now, this is a very important point. With cervical myelopathy, the goal of surgery is to prevent further damage to the spinal cord and prevent further loss of neurologic function. No matter what surgical approach we use, we can't guarantee that patients will return back to 100% normal neurologic function. To a certain extent, the damage to the spinal cord has been done, and the spinal cord is not very good at healing itself back to 100% normal. So successful surgery is one that prevents patients from falling further down that green line on the graph. Next slide. So what does surgery look like for this? There are several different procedures that we have to offer to help relieve the pressure on the spinal cord. The exact procedure we recommend depends on many different factors, including which symptoms you're experiencing and the levels of the spinal cord that are involved. It's our job as your spine surgeon to factor in all of this information and recommend the option that's going to give you the best chance of a long-term success. So let's review some of the surgical options here. There are generally two categories that we have. There's anterior, where we access the neck through the front of the neck. And then there's posterior, where we access the spine through the back of the neck. First, we're going to talk about the anterior surgical options. If you look to the top right on the slide, we have an anterior cervical discectomy and fusion, or an ACDF, where we remove the disc, we decompress the spinal cord, and then we put a bone graft where the disc was. We secure all this in place with a small plate and screws. Now, this is a fusion procedure where we want the two vertebrae to heal together into a single solid bone. Now, if you look to the bottom right of this slide, this is an anterior cervical corpectomy and fusion. It's very similar to the previous option, but with this surgery, we have to remove bone from the vertebra and not just the disc to access the canal and decompress the spinal cord. Just like an ACDF, we replace the structures that we take away with a bone graft, And our goal is to get everything to heal and fuse together. Moving on to the bottom left, this is a newer procedure that allows us to avoid fusion. It's called a cervical disc replacement. During this, we remove the disc, but we replace it with a mobile spacer instead of a bone graft. This allows the two vertebrae to continue to move on one another and avoids a fusion. This is really an exciting advancement in spine surgery because it avoids a lot of the downsides of a fusion. It not only preserves more of your neck motion, but it also avoids increased stress on the levels above and below the fusion, which can lead to accelerated breakdown and degenerative changes. Generally, if we can opt for one of these motion-sparing, non-fusion procedures, we like to, but not everyone is a candidate for it. Sometimes the best option for patients to ensure long-term success is a fusion procedure. So ultimately, your surgeon needs to make that decision with you. Next slide. Sometimes the better option is to access the spine through the back of the neck. We have two main options here. The first is a laminectomy and fusion, which is shown in the image to the top right. In this procedure, we remove the roof of the spinal canal to decompress the spinal cord, and then we stabilize the spine using screws and rods. This is another example of a fusion procedure. So like we talked about on the last slide, the goal is to get these bones to heal and mend together. The other posterior surgical option is a cervical laminoplasty, shown in the two pictures along the bottom here. During this procedure, we make cuts in the bone that allows us to hinge it open like a book to create more space in the spinal canal. Once we hinge it open, we place these small plates and screws to hold it in that open position. Although we're using plates and screws here, this is not a fusion procedure. Just like the cervical disc replacement on the previous slide, this is a motion-sparing, non-fusion procedure, which brings with it all the benefits that we talked about previously. Next slide. The recovery for all of these different procedures has a lot of variation, depending on the type of surgery and the number of levels that we need to operate on. Depending on the type of procedure, you may be able to go home the same day, but more commonly, we tend to keep patients in the hospital for 1 or 2 nights. After the surgery, you'll have a dressing over the incision. We generally tell patients to keep their incision clean, dry, and covered for the first week after surgery. Then after that first week, you can leave it open to air. Sometimes our fusion procedures will put you in a hard collar, like the one on the right, to protect your neck as it heals. Often with the motion-sparing non-fusion procedures, we can avoid using a collar at all. With the surgeries that go through the front of the neck, we work very close to the esophagus or the swallowing tube. So it's very common to have some throat soreness and some difficulty swallowing for the first week or 2 after surgery. But this gradually gets better as the swelling goes down. As far as activity restrictions after surgery, we generally tell patients to avoid excessive bending or twisting of the neck and no lifting more than 5 to 10 pounds. But you have unlimited walking privileges after all of these procedures, and we encourage you to get up and move around as often as you can. Next slide. So I know that was a lot of information. Let's now open it up to questions, and I'm more than happy to clarify anything that we went over. All right, so how often can injections and/or an RFA, which is a radiofrequency ablation, be used to reduce the pain from bulging discs in the neck? So with cervical myelopathy, when you have compression of the spinal cord, there isn't much of a role for these injections. But sometimes when you have cervical radiculopathy, which is also at the neck, it's where just the nerve root is pinched instead of the spinal cord itself, we can trial non-operative management. This non-operative management consists of things like medications, physical therapy, injections, and then last resort, when all that fails, is surgery. Generally, the steroid injections can happen every 3 months or so is generally what we aim for. Any more frequently than that, you just don't want to have the risks associated with a high dose of steroids for long term. And generally, if the injections are not lasting any more than 3 months, then we may need to look at other options for you. The RFA, or the radio frequency ablation, is mostly used for neck pain symptoms, so not necessarily neurologic symptoms. So when you have compression of nerves, whether that's the spinal cord or the nerve roots coming off the spinal cord, there usually isn't much of a role for an RFA. But if you're having a lot of neck pain, sometimes that can be an option. Can a herniated disc in the cervical spine cause a sensation of pressure on the chest, right below the throat, accompanied by a need to wheeze and cough? Not generally. Cervical spine issues don't really affect the chest, uh, and they don't really cause any kind of wheezing or coughing. That may be something that you need to go to your primary care doctor for to get further evaluated. Can tight muscles, along with cervical stenosis, cause dizziness? If you have been through PT and dry needling, what other options are available? So dizziness. With cervical myelopathy, you can have issues with coordination, gait instability, with your balance, but generally patients won't describe a feeling of dizziness like the room is spinning around them. Oftentimes, if you're having that kind of sensation where the room is spinning around you or you're dizzy, that can be caused by other things. The sensation from cervical myelopathy, you're not necessarily feeling dizzy, but you just feel uncoordinated. You find yourself tripping over your feet, losing your balance, things like that. Tight muscles won't per se cause these issues. And cervical stenosis, like I said, won't necessarily cause the dizziness. If you're having that sensation of dizziness where the room is spinning around, again, that might be something better to talk to your primary care doctor about to see what other potential diagnoses could explain your symptoms. Can injections fix a cracked vertebra? If you have when you say cracked vertebra, I'm assuming you mean a fracture or a broken vertebra. That can happen after falls or other trauma. Uh, the vertebrae are bones, just like the other bones in your body. And when the bones are given time, they do heal. A lot of times we'll immobilize the vertebra in the spine, either with a collar or a brace to help support it as it heals. But really, time is our friend here. It just takes the body the body time to actually heal itself and fix the fractured or the broken vertebra. Injections won't necessarily heal the vertebra, but there is one injection that we sometimes recommend for compression fractures. Compression fractures are a type of break or fracture in the spine that happens when our bone quality weakens to a point that even low energy falls or things like that can cause the vertebra to actually crunch down and cause what we call a compression fracture. In some patients that have continued severe pain with compression fractures, we will recommend a procedure called a kyphoplasty. And in that procedure, they basically place a percutaneous needle into the vertebra and inject cement into the vertebral body that's broken. Now, this does not heal the fracture, but it can reduce the amount of pain a patient's having from that fracture. So that's oftentimes why we recommend that. Can spinal stenosis cause pain from neck into the back of the head going upward? Sometimes it can, depending on which nerve roots are getting pinched in the neck. Sometimes you can have some symptoms that kind of radiate up into the base of your skull a little bit. More commonly, pinched nerves in your neck do cause pain in the shoulder, around the shoulder blade, and down the arm into the hand. But when you have pinched nerves that are towards the top of the spine, you actually can have some sensations of pain that radiate into the back of the skull over here. What is the difference between cervical myelopathy and neuropathy? Great question. So when we say neuropathy, we're talking in general terms that nerves are not functioning properly. Oftentimes, when I say a patient has neuropathy, it usually has, I'm usually referring to chronic nerve damage, usually in the hands and feet, that's related to things like diabetes can cause neuropathy. Certain chemotherapy drugs, when being used for cancer treatment, can cause neuropathy. But it's generally a dysfunction of those nerves, especially in the hands and the feet that we refer to. That can cause chronic numbness, tingling, pain, sensations like that. Cervical myelopathy is specifically compression of the spinal cord itself. So neuropathy can cause some of the similar symptoms of cervical myelopathy, but myelopathy refers to the spinal cord being compressed and causing those symptoms. Neuropathy can be caused by a bunch of different things. Which is the best sleep position for cervical myelopathy? On the side, the back, or the stomach position? So there's no right or wrong answer here. I generally tell patients, when you're laying in bed, you're not necessarily going to hurt anything. You're not going to make anything worse. It's all about comfort and which position feels better to you. It's really just trying out the different positions, seeing what feels best for you, and you can go with that position. But there isn't a specific position that makes cervical myelopathy better or worse. What stretches can you do to relieve the neck pain caused by cervical myelopathy? So cervical myelopathy itself generally does not cause neck pain. Neck pain can be caused by a lot of different things. It can be really hard to pinpoint exactly what's causing neck pain. It can be caused by the bones, the nerves, the ligaments, tendons, muscles. There are a lot of different causes of neck pain. And we do like physical therapy for neck pain. And when we send you to physical therapy, they're going to teach you a bunch of different neck strengthening exercises and stretches to do that can make it better. Within this short video, we're not going to be able to kind of go through all the stretches that you would need to know to treat neck pain. But if you're having issues with that, we're happy to see you. We're happy to coordinate a referral to physical therapy, and they can teach you all the exercises and the stretches that you need to know. What is the first symptom that patients usually notice? The tingling and weakness, is that on one side or both sides? Great question. So the presentation can be different depending on the patient, depending on where the cord compression is, the severity of the cord compression. I would say usually the most subtle first symptoms are issues with hand dexterity and issues with balance. And so patients aren't necessarily having a lot of pain, a lot of numbness, tingling that really prompt them to say, what's going on here? I need to go see a doctor. And so the issues with hand dexterity is that clumsiness of the hands that I was referring to. You're trying to do something like write with a pen or pencil or button a shirt. You might find yourself dropping items more frequently. Those are those subtle findings of issues with hand dexterity that can be one of the earliest symptoms of cervical myelopathy. And then issues with your balance, like I was talking about, a feeling of like you're about to fall, lose your balance. You find yourself tripping, losing your balance and falling more frequently, having issues going up and down stairs because of your balance. Oftentimes, those are the first symptoms that present, but it can be highly variable. The tingling and the weakness is often bilateral, meaning it affects both sides. And that's a main difference of what we were talking about earlier, cervical radiculopathy and myelopathy. When you have cord compression, it tends to affect both sides. When you have nerve root compression, a lot of times it just affects one side. All right, so that wraps it up. That's our OrthoCarolina live webinar this evening. A replay of this will be posted on our social media channels. Thank you, everyone, for attending, and have a great night.